Good morning, good afternoon, good evening. Ciao. Hi, everyone. It's a pleasure to welcome you here about the Reconnet and APS family today to discuss a hot topic like the antiphospholipid syndrome, how to explain my disease to family and friends with two very special guests, people that they don't need in this community any presentation. We have Silvia Aguilera, our EPAG of the Reconnet, and Professor Ricard Cervera. They are two real pillars of this disease, and it's my true pleasure to give them the floor and to discuss this very important topic when we have to liaise among physician, patient, and people dealing with this condition. So the floor is yours, and I hope you will all enjoy.
Thank you very much, Sabino. I think the pleasure is shared that you are here today helping us moderate this webinar. So we are here today for a patient-directed webinar explaining antiphospholipid syndrome and how can we explain our syndrome to family and friends. Next slide, Ricard, please. So when you get a diagnosis, when you get diagnosed with APS, as a patient, you have a lot of emotions and a lot of information to go through and a lot of discussions with your doctor that you have to do alone with your process. But at the same time, you transmit this diagnosis as well to your family and you bring them on board and to your friends. And then, next slide, Ricard, you have to go through all this process yourself and you have to read about what is going on and what it means to be diagnosed with APS. But then people start asking you questions. Why did you get it? Can you have children? Will you get cured? Many, many things that maybe you didn't even think about that people start asking you and you have to answer to these questions. Next slide, please. So we are here today to help you answer some of these questions and maybe some questions that people have asked you, maybe some questions that you still have, and maybe to help you as well explain better what APS means to your friends and family so they can support you better. So our first question is, Dr. Cervera, how does APS develop? How do you get APS? How does this happen?
Thank you very much, Silvia, for asking me this question, this very, very important question, and for allowing us, thank you, ERN, Reconnect, to talk to the patients and families on this terrible problem that is the antiphospholipid syndrome. Well, first, how does APS develop? Well, we have to say that the antiphospholipid syndrome is an autoimmune disease that increases the blood coagulation. So the problem due to this disease is that patients can present clots, can present thrombosis in any part of the body, in any vein or in any artery of the body, the legs, the brain, the kidneys, the heart. It is not an infectious disease, for sure. So it is not possible to have a contagious problem because of this. It is not a malignancy or a cancer. It is not a genetic disease, but there is certainly a genetic predisposition. This means that in some families, there are people that present autoimmune diseases, and one of these autoimmune diseases that can be present in this family can be the antiphospholipid syndrome, and maybe with a sister with lupus, and maybe with a cousin with autoimmune thyroiditis, and so on. But this is what we call a genetic predisposition. So it is not a genetic disease as such.
So, Ricard, first questions. Why do we get APS? Why did I get APS? Did I do something? Is there a trigger? Could I have done something not to get APS?
Well, the problem is that the presence of antiphospholipid antibodies that are the ones that produce this syndrome is something that in some way has this genetic predisposition, so you cannot do anything to have or not to have these antibodies. But why this thrombosis appears one day or another day? We have a theory that it's the theory that we call the double hit theory. That means that there is a first hit, that means that you have antiphospholipid antibodies, because maybe this genetic predisposition. But something happened as a second hit in another occasion, in some circumstances, that make to develop the thrombosis at that moment. And now we know that there are some factors that can predispose to this development of the disease, this second hit. For instance, we know that some infections or some surgical procedures or some immobilization, sometimes some inflammation, like the presence of lupus, can be this second hit that makes to develop the thrombus, the clot, in a given moment. Certainly, the only important thing is to have probably a healthy life that tries to avoid these general factors that can produce this second hit, especially if you already know that you have these antibodies. This is the only aspect that you can in some way modify, that you can control. But the presence of the antibodies, as I mentioned, probably has some genetic predisposition, and certainly you cannot do anything to avoid the presence of these antibodies. And what happens? What happens if you have these antibodies and then there is the second hit, is that appears the clots. Clots that can appear, as I mentioned you before, in any part of the body, the arteries, the veins, any part of the body. But it is also very interesting that some of these coagulation problems are related to pregnancy. And then pregnant women can present some more specific manifestations related to the antiphospholipid antibodies. Can present pregnancy losses, can present premature birth, can present some obstetric problems, some pregnancy problems such as preeclampsia, eclampsia, placental insufficiency, can present early pregnancies losses, what we call spontaneous abortions. And we consider that in many cases, this is because of these coagulation abnormalities in the placenta, in the circulation, in the vessels that lead the blood from the mother to the fetus, to the baby. There are different types of antiphospholipid syndrome. Roughly, there are two groups. What we call the primary antiphospholipid syndrome, that is when patients present just with this autoimmune disease, the antiphospholipid syndrome, clots due to antiphospholipid antibodies. But in many occasions, this antiphospholipid syndrome appears together with another autoimmune disease, mainly lupus, mainly systemic lupus erythematosus. That's the reason that there is this close connection. These are two different diseases, but in many cases, they are going together. 30 to 40% of patients with lupus presents also the antiphospholipid syndrome. 30 to 40% of patients with primary antiphospholipid syndrome develop, or with antiphospholipid syndrome, develop also lupus. Another classification of the antiphospholipid syndrome is depending on the main clinical manifestations. We say on one side thrombotic, clots. In another possibility is mainly obstetric, pregnancy losses and pregnancy complications. But sometimes can appear both. Some patients present both thrombosis and these obstetric problems. And then there are two very rare variants of this antiphospholipid syndrome that it's worth to know, although they are very rare. On one side, the catastrophic antiphospholipid syndrome, we are going to talk later, it's a severe variant of the antiphospholipid syndrome, and the neonatal means that are the antiphospholipid syndrome that appears in the babies just after the birth. And another important issue is how we make this diagnosis. of the antiphospholipid syndrome. And here, I think that it's important to distinguish two terms, two concepts that we are using, we doctors, we are using a lot, and sometimes are confusing, especially for the patients. The concept of diagnostic criteria and the concept of classification criteria. In rare autoimmune diseases, such as the antiphospholipid syndrome, lupus, systemic sclerosis, many of these diseases that are covered at the ERN Reconnect, there are no gold standard for the diagnosis. There is not any specific test that makes 100% the diagnosis of the disease. Like, for instance, if you have an infection, you can make some blood cultures, for instance, and then you discover the microbial agent, and then you say this is an infection due to, let's say, salmonella. Well, in the autoimmune diseases and the antiphospholipid syndrome, this doesn't exist. Because of this, we, the physicians, have created some kind of epidemiological tools that are the classification criteria. The diagnosis is something that we physicians do with each patient, each one individual patient. And then usually we try to exclude other diseases. That's the reason that usually we perform several tests in order to see, well, this can be the antiphospholipid syndrome, but can be other diseases. Let's do this test. We exclude, we rule out other diseases, and we say, well, because of this thing, we believe that your diagnosis is the antiphospholipid syndrome. And in this case, what we call sensitivity, the ability to detect as many patients with the disease is very important for the diagnosis. By contrast, what is used many times, and you will see that it's sometimes what you have many times in the records written, the classification criteria, these are mainly for scientific studies. In this case, what physicians want is not to diagnose in a specific person the disease, but to be sure that a group of patients certainly have the criteria, the features that are consistent with this disease in order to perform different research studies or clinical trials in order to have better therapies. So this is not an individual work, but it's something that we do for groups of patients. And here, a specificity, not sensitivity, a specificity to be completely sure that this is the antiphospholipid syndrome and not another thing is key for the classification criteria. So it's very important that when we make the diagnosis to a patient, we are on the left-hand side of this slide. This is something related specifically to this person. And when we say the classification, this is mainly for research activities, not for that patient that we have in our clinic. And the important thing is when we suspect that there is an antiphospholipid syndrome, usually we suspect if there is a person, a patient that presents with the clinical problems that we mentioned, with clots, thrombosis in any part of the body, or with these pregnancy problems. And together with this, we found in the lab some antibodies that are called antiphospholipid antibodies. The clinical manifestations, the ones that we mentioned, thrombosis and pregnancy losses, and the lab, the laboratory criteria, the antiphospholipid antibodies. They have funny names, these antibodies. First one is lupus anticoagulant. This is a laboratory test that it's quite old. It was it was discovered in the 60s of the past century, of the past millennium. And then two that are more recent, that are the anti-cardiolipin antibodies IgG or IgM, and the anti-beta 2 glycoprotein 1 antibodies IgG or IgM. These are the most important antiphospholipid antibodies. And we usually, if we detect in the lab, we usually repeat again this to check, because sometimes it's a little bit difficult, the detection in the lab, and can be probably false positive results. So we always, and you will see that you are a physician, usually these are positive, they ask again, repeat, please repeat. After several weeks, after usually 12 weeks, repeat this in order to confirm that you have these antibodies.
Okay, this is getting a bit complicated. So we have the 3 antibodies, but Dr. Cervera, you said lupus anticoagulants, but then does this mean that I have lupus or I can develop lupus? What does this mean? And what is this IgG and IgM kinds of antibodies?
I already said that this is a little bit complicated with funny names. For instance, funny name is lupus anticoagulant because it is a false name. It is not lupus. It is not lupus at all. It's antiphospholipid antibody. But this was the term that in the 60s, as I told you, this is a very ancient test. In the 60s, the doctors at that time believed that they believed that this was because of lupus, but it is not true. So there are many patients that present this lupus, so-called lupus anticoagulant, but without lupus. And actually, it is not anticoagulant. I am saying all the time that this is a thrombosis, a clot, so it's procoagulant. But it's a funny name because in the lab, it's very curious. In the lab, when the lab technicians perform the test, it is anticoagulant. But in vivo, in life, in the human body, it is procoagulant. It's very, very funny, very complicated. And even much more complicated is what we call the IgG and IgM. The antibodies can have different forms. These are proteins that are inside our blood, and these proteins can have different configurations. And then the immunologists have found several configurations: the IgG, IgM, AGA, IgE. And in this case, the two more important that we have found is the IgG and IgM. And both are important, although we believe that it is a little bit more important, more dangerous to have the IgG isotype. That's the reason that sometimes the physicians look, well, but it was IgG or IgM, because IgG, this protein in the form of IgG, it's a little bit more procoagulant than IgM, but both are antiphospholipid antibodies.
Perfect. So can we suspect APS? Is there something that is not, because you explain now it's clear how we diagnose and the difference between diagnostic criteria and how do you diagnose? Are there anything that is not in these criteria that we could have?
Well, actually, there are other manifestations. In addition to these clots and the pregnancy problems, there are other manifestations that are less specific, but sometimes many patients with the antiphospholipid syndrome also present low platelet counts. It's called the thrombocytopenia, or anemia, specific anemia that it's hemolytic anemia, or can have heart valve lesions, or can present with neurological problems such as epilepsy or severe migraine. These are not as specific, not as typical of the antiphospholipid syndrome, but many patients certainly can have these and other manifestations. And then, as there are many different manifestations, many antibodies, it appears the concept of classification. But as I told you, this is a concept mainly for research study. And the first one who created the first set of classification criteria, and I put just this slide in order to put his picture, is Dr. Professor Graham Hughes from London. He was the first person who really considered that the antiphospholipid syndrome was a new entity, a new disease, and this was just recently in 1983. And he did a lot of research on the antiphospholipid syndrome. So it is really important to honor his name. And this here you have the picture of Dr. Graham Hughes. And later, over the years, we physicians have created all the criteria. And from time to time, we changed these criteria. In 1988, we made the Sapporo criteria. In 2006, we made the Sydney criteria, usually because we gather in these cities. And just very recently, we have done a much more complicated set of criteria that has been done in a collaboration between EULAR and ACR, the European and the American Societies, Federation of Societies of Rheumatology. These are certainly much more complicated, and I just would like to emphasize that this is mainly for research activities, mainly for physicians. When we made our studies, we use these complicated classification criteria. And I mentioned you that there is a rare variant, very uncommon, but terrible, that it's the catastrophic antiphospholipid syndrome. You can imagine that with these names, this is certainly terrible, and it is. It is a form that is uncommon because less than 1% of the total number of patients with the antiphospholipid syndrome present this catastrophic variant, but it's terrible. They appear thrombosis in many organs, in 3 organs or more, just in a few days, less than a week usually. And usually the thrombus appear in the small vessels, in the capillaries of the circulations, and this leads to the failure of the organ. These are patients that have cardiac failure, respiratory failure, renal failure, usually are in intensive care units. It's really a terrible situation with a high mortality, but thanks to the work that we have done, the physicians over the years, now we have learned a little bit more how to treat this condition with more intensive therapy. We also know in some way how to prevent, because we know that there are some triggering factors, some factors that can make to appear these catastrophic forms, such as infections, some surgical procedures, problems with anticoagulation. So we have to take care of this in order to try to avoid the development of the catastrophic variant. And now it's the treatment, how we treat the antiphospholipid syndrome. And first of all, I would like to stress that usually we try to get agreements between the physicians working on this. And nowadays, these main agreements came through the European League Against Rheumatism, the EULAR recommendations that from time to time made recommendations for many autoimmune and rheumatological diseases, including the antiphospholipid syndrome. And we did these recommendations in 2019, so very recently. And what is also very impressive is that most of the doctors that did these recommendations for the management, for the treatment of the antiphospholipid syndrome, are members of this ERN-RECONNECT. Nearly half of the authors of these recommendations are the doctors of this ERN-RECONNECT. And mainly the treatment that we use are based in two therapeutical tools. On one side, anticoagulants. On the other side, antiplatelets or antiaggregants. Though we also use sometimes other drugs, hydroxychloroquine, some vitamins. That's it. Anticoagulants is the main therapy. There are different groups of anticoagulants that we can use. What we call the antivitamin K, heparin, or a more modern, the direct oral anticoagulants. Antivitamin K are the classic oral anticoagulants. There are 2 very commonly used, warfarin and acenocumarol. Coumadin. They are very safe if they are well controlled and you take care of this control. But you can take this for years and years without other side effects. The problem is that they present some interactions with food, with other drugs. So it is very important to make a dosage adjustment and to make controls. It needs to make a blood test quite often in order to check that it is inside the INR, the International Normalized Ratio. This is a formula that hematologists, hemostasiologists have created. And at the end of the day, let's say a healthy person usually has an INR between 0.8 and 1.2. And a person that is anticoagulated, it is higher. It is between 2 and 3. And sometimes we put this between 3 and 4. That means much more anticoagulated. And we control this by means of some tests that can be performed either from the veins, from the blood from the veins, or directly from capillary veins. The patients can also do themselves in portable machines. So it can be done as self-checks, but not all patients can do this self-check using this portable machine. Patients with antiphospholipid antibodies, especially with the lupus anticoagulant, can have problems with this. So most of the patients with the antiphospholipid syndrome still need to do the blood test for checking in veins. The second anticoagulant is heparin. Heparin, you can give this by subcutaneous injection or by intravenous injections. There are several forms, the unfractionated and the low molecular weight, but this can have side effects in the long term. So it is not possible to keep on heparin for many months or for many years. It is not as difficult to adjust, or it is not necessary to adjust using the INR. Usually we adjust according to the weight, sometimes using some tests, such as the antifactor 10A. And then there are the modern anticoagulants, also oral anticoagulants, what we call the direct oral anticoagulants, rivaroxaban, apixaban, and so on. They have a great advantage. They have very few interactions with other drugs or with food. So you can give a fixed dose, always the same dose, no control, no routines, no INR test. So it's very simple for patients. But unfortunately, most patients with antiphospholipid syndrome don't benefit of these new oral anticoagulants because they don't protect enough. They can have thrombosis, especially arterial thrombosis, if they use these anticoagulants. So that's the reason that the official regulatory medical agencies, for instance, the European Medical Medicines Agency, has established that it is not recommended to use these new direct oral anticoagulants in patients with the antiphospholipid syndrome. So in general, we don't use them. Yeah, can be probably in some cases exceptions, but in general, these are not used in patients with the antiphospholipid syndrome. And then we have the antiplatelets, antiaggregants that are usually aspirin, clopidogrel. Usually they avoid platelet aggregation, can have some interactions with food and drugs, do not affect the INR.
So, Dr. Cervera, so who takes what? Like, yeah, I am not taking aspirin, but I know some people that are taking aspirin, and I know people that are anticoagulated, that they have a different INR range. Like some people have from 2 to 3, some people from 2.5 to 3.5. So where does this come from? What are the differences? How do we know what the drugs we should take?
That's a key question, because we have different options now when we use one or another option. And back to the EULAR recommendations, let's see what this group recommended. And we will see different options, different scenarios. For instance, what we call the primary thromboprophylaxis. This means prophylaxis prevention of thrombosis in patients that never had in the past one episode of thrombosis. But we have found these antibodies because probably the patient has lupus or other autoimmune disease, and then the doctor has asked for these antibodies, or the patient presented pregnancy morbidity due to the antiphospholipid antibodies, but never thrombosis. Well, in these cases, with no previous thrombosis, we usually do a low level of treatment, and we use the antiaggregant in most of the patients, usually aspirin at low dose. Then is what we call the secondary thromboprophylaxis. That means the patients that already had a thrombosis, and now we have to do something in order to prevent another thrombosis, a second thrombosis. In the case of venous thrombosis, well, we usually give the classic anti-vitamin K treatment, warfarin, coumadin, and usually we keep at an INR between 2 and 3. But some patients with this treatment present another thrombosis. What to do then? Well, we can do either increase the INR, and then we ask to be in an INR between 3 and 4, or we add aspirin, low dose aspirin, or sometimes we change to heparin, to the, for instance, subcutaneous heparin. So these are different scenarios. And then secondary prophylaxis in the case of arterial thrombosis. A patient presents, for instance, a stroke, and then we have to prevent for a second stroke or for a second thrombosis. Usually what we do is, again, anti-vitamin K, Sintrom, coumadin, warfarin, usually at an INR between 2 and 3. And then, if there is not enough with this, again, we increase the INR to between 3 and 4, or we add low-dose aspirin, or we change to low molecular weight heparin. And regarding the obstetric problems, and I have to tell you that also we have another webinar in this Reconnect ERN that was done. Yes, it was done by Silvia and Professor Angela Tincani. So I recommend that you check this webinar. And in summary, what we do in the cases of the presence of antiphospholipid antibodies in case of pregnancy is first, if no previous problems, no previous pregnancy complications had the patient, we usually give aspirin, low-dose aspirin. That's very simple, low-dose aspirin before pregnancy and all over the pregnancy, If the patient had previously some pregnancy problems, abortions, fetal losses, eclampsia, usually we give this aspirin plus heparin. Usually subcutaneous, low molecular weight heparin all over the pregnancy. If this doesn't work, it's something that unfortunately sometimes happens. Now with this therapy, with low-dose aspirin and heparin, we manage to succeed in 80%, even 90% of the cases. But if this 10 to 20% of the cases that this is not enough, then usually we have different options to give more heparin, to increase the dose of heparin, to add hydroxychloroquine, like in patients with lupus, to add prednisone, especially at the beginning, the first trimester of pregnancy. Also, we have intravenous immunoglobulins, which is a much more sophisticated therapy, but this in some cases we can give this. And obviously, if the patient presented before the pregnancy presented thrombosis, it's very important to keep the patient all over the pregnancy with aspirin, low-dose aspirin, plus heparin at a therapeutic dose. dose that usually is a higher dose than the dose that we give just for the pregnancy problems. And then is the catastrophic antiphospholipid syndrome, this terrible variant. In this case, we do more therapies. Obviously, we take care of the triggers. If there is an infection, we have to treat the infection. But usually what we do is to give what we call the triple therapy. We give anticoagulants, usually heparin. We give prednisone, glucocorticoids, and we give also plasma exchange or intravenous immunoglobulins. Plasma exchange is a way to clean the plasma, to clean the blood, to take out the blood and then to return the blood in a clean way, or intravenous immunoglobulins. This is a very complex procedure, but thanks to this, certainly the prognosis has improved over the years in patients with catastrophic antiphospholipid syndrome. So recently we have some new therapies, some biological therapies, such as rituximab, eculizumab, that are therapies that we also can give in some of our patients with catastrophic antiphospholipid syndrome, and they have improved the survival of these patients. But I would like to stress that we have mentioned many treatments, different dosages, different combinations. In one patient we give one, in another patient we give another one. So it is important that not all the therapies probably are adequate for each patient. So each patient will require an individual approach, and this is very important. That is the task of the physician to take care of this. So don't worry if you see I have antiphospholipid syndrome, but I take different tablets that my friend that also has the antiphospholipid syndrome. This is something that is based on these different types of the antiphospholipid syndrome and the different therapies that we have to combine in the different cases.
So maybe, Dr. Cervera, we can finish with what is and we were just a few weeks ago in the European Congress of the Rheumatology Alliance, Association of Rheumatology Alliances, and we saw a lot of APS. There was a very nice session in which we talked about APS, and maybe the thing that a lot of people ask us, will there be a cure? What is the future? Are there people working on APS? Because patients don't know what is being done by researchers. Can you tell us a bit about the future?
Well, for sure that there will be a cure one day. The question is if this day will be in several years, in many years or so, but there will be, thanks to research. I give you positive information. There are many people working in Europe, all over the world, a lot doing research on the antiphospholipid syndrome. There are many lines of research that maybe step by step, slowly, but we will improve our knowledge of the antiphospholipid syndrome, and we will have for sure in the next few years better therapies to control the disease. And one day we will have for sure a cure of the disease. And I suggest for those of you that are still interested in knowing more on the antiphospholipid syndrome, even in knowing which is the research that we are doing, we have here several websites where you can find much more information on the antiphospholipid syndrome and on the antiphospholipid syndrome research. Thank you very much for your attention.
Thank you.
And we thank you, Ricard and Silvia, for this amazing mosaic of what we know, what we should know, and which is the future about the antiphospholipid syndrome. I truly enjoy it, and going through the comments in the chat, I feel that I was not the only one. So let's just start breaking the ice, because it's not common to have two experts of APS that we can ask whatever goes through our mind. So I start sharing some of the comments, and feel free you both to start answering. One of the recurrent questions was if there is a link or a possible association between the onset of APS and condition like stress or emotional issue. And we know this is a common question across different autoimmune disease. What's your perspective? What we should think about it?
For sure, there is a link, and this goes in what we call the double hit theory. Patients certainly have some predisposition, have the antibodies, have some genetic background, but because of something, this something is in many occasions is a stress, is a terrible problem in their lives. Some psychological issue. This can be the trigger, the second hit that makes to develop the disease in a given moment, that makes to produce the clot in a given moment. Also, there are infections, there are surgical procedures, sometimes inflammation due to lupus, for instance, a lupus flare can also precipitate a thrombus in a patient with antiphospholipid antibodies and so on. But for sure, stress. So that's the reason that can we do something to avoid having problems? Well, try to have a life with less stress. That can be the answer, which is probably much more difficult than just taking a pill, but that's a general consideration.
Thank you, Ricard. Thank you, Professor Cervera. And now let's try to move to the other side of the coin. And probably I want to share a question that probably, Silvia, you have received as our EPAG several times. What's your suggestion to a person when first receive the diagnosis of APS? How we can help to digest better this changing in the life of this person?
So I think, and everyone that works in the network knows that I'm a very big advocate for patient associations. And I think that in Europe, we are very lucky to have federations and national associations at the country level. And I think that one of the first places we should turn to are patient associations, which are mainly constituted of people like me. I am in the Spanish APS Patient Association, and we are able to welcome you and answer your first questions and reassure you that we are living with the condition, that life continues, that is, and you have to get used to a new life, maybe sometimes, after getting diagnosed and after passing through what happened before diagnosis, which is sometimes quite traumatic. But I think that the first thing is to look for patients like you, and to look for support and to see that there is life after being diagnosed, and that there's life can be actually quite good and very nice, even if we are diagnosed with APS.
Thank you, Silvia, for sharing. And indeed, I think that we are all here to help each other from different perspectives, but probably the bottom line that nobody should feel alone in this adventure. And now I move back to Professor Cervera, moving to some more technical question. Probably one of the attendees was asking if there is a link between APS and lupus. And this is probably one of those $1 million questions.
That's true. And actually at the beginning, when Dr. Hughes, remember the picture that I show of Dr. Hughes from London, who was the first person who considered that this was a new condition, he believed that this was lupus. At the beginning, it was believed that this was just a variant of lupus, like lupus nephritis or like neurological lupus. This was some kind of thrombotic lupus. But then we realized that certainly many patients presented both lupus and the antiphospholipid syndrome, and others presented just the antiphospholipid syndrome. And some patients present antiphospholipid syndrome plus rheumatoid arthritis or plus systemic sclerosis or other diseases. So there is a link because both are autoimmune diseases, but they are in some way they are different. For sure, when they are autoimmune diseases, this means that the immune system is disturbed, has problems, and probably there are some immunological links between the problems that appears in lupus and the problems that appears in the antiphospholipid syndrome. But this is more at a basic immunological level. In summary, these are two conditions that many times can appear together, but others can appear separated.
Thank you. That's very clear and very interesting. And now keep going in these questions that are popping in. Now I would ask to Silvia, sharing one of the questions that is appearing here, is how APS can affect traveling, long flight, staying in one position, and what we should share with people with APS from this perspective.
Oh, this is very interesting because everyone is thinking about the summer, and maybe someone with APS is thinking about traveling. So it's very interesting. So it's I have to say that it depends as well. You should talk to your doctor if you need to do something specific. It depends as well if, for example, you're taking a super long flight and you've had clots in, for example, your legs, and you might have these compression stockings that we use for long flights. There are some people that also take heparin before long flights, but we see that it really depends on what Professor Cervera was telling us before. Not all APSs are the same, and not all APS patients are the same. So you have to make sure that if you're anticoagulated, you have your control machine, you can take it on holidays. And this is a very good idea to continue with a good anticoagulation whilst you're going on holidays, and good hydration, and to check it before a flight. Ask your doctor if they consider that you need to take heparin. If you have compression stockings, obviously wear them if you're going to go on long flights, and move around. I am the ones that gets on the plane, and after 1 hour, I'm talking to the stewardess up and down because I need to move around. But talk to your doctor and ask them, make sure that you are well controlled during your holidays and even before, so that you can go calmly. Do not forget any of your medications. This is super important. But yes, check with your doctor just to be as calm as possible and have a great trip, as well as when you come back.
Thank you, Silvia. And on the same line, we were mentioning anticoagulants, and one of the questions was which are the potential side effects of what we technically call vitamin K antagonist. In the chat, acenocumarol was mentioned. What we should be worried about in this sense?
Well,
Ricard,
the first
can you help us?
Yes, the first concept is that what we do with these anticoagulants is to anticoagulate the blood, is to make the blood more liquid. So just the contrary of the problem that patients with antibodies have, that the blood is more sticky. So if we give too much anticoagulants, we can have hemorrhages, we can have bleedings. And this can happen if you, by mistake, you take a higher dose than recommended, or sometimes because of interactions. As I mentioned before, there are some food, some drugs that can interact with these anticoagulants. So that's the reason that when you are taking these oral anticoagulants and you are prescribed to take another drug, an antibiotic, for instance, always is very important to check with your doctor if it is possible to take this, because there is no interaction. And it is always very important to do this routine test, this INR, in order to check that you are in the range between 2 and 3 or between 3 and 4. Roughly, if you have higher INR, you are at a higher risk to have a hemorrhage. But it's not a question. Patients don't have to worry. If they are 4.1, they are not going to bleed. They are more range, but you have to try to be in this range, in the therapeutic range. Too high is risk of bleeding. Too low means that you are not anticoagulated and you have the risk of thrombosis. So these are the main risks using these tablets: hemorrhage or no effective, and then thrombosis.
And if I can summarize some of the comments that also appear in the chat, I think that the key is also communication. Be informed when the medication is prescribed. If any doubts arise, asking if this can be related or not to the medication. And if it's not clear, we as a medical community, we are all here and the patient association try to do our best to be as clear as we can. And so ask, because I think this is communication is a big part. And going through the question, there is another, and if the previous one was 1 million, this is probably $10 million question, Ricard. So get ready. What about false negative APL testing? Is this possible?
I can see that they are very, very educated people following this webinar, because they know a top $10 million questions that we physicians have is what we call the seronegative antiphospholipid syndrome. As I mentioned at the beginning, to make the diagnosis of the antiphospholipid syndrome in a given patient, we do when the patient presents with the manifestations, the thrombosis or the pregnancy problems, plus this positive blood test. We need this blood test, and also we need twice, because sometimes once can be just a technical problem, an error. So we need twice. But sometimes we believe clearly that this patient has an antiphospholipid syndrome because presents all the clinical manifestations, probably also presents with lupus. And then we look for these antibodies, we go to the lab, and these antibodies are negative. And then maybe it's because certainly this is not an antiphospholipid syndrome. But we put the question, maybe it's because they have a seronegative antiphospholipid syndrome. That means that the blood tests are negative. This is something that we believe that it exists because in addition to the antibodies that I mentioned you before, those with funny names, lupus anticoagulant, anticardiolipin antibodies, IgG and IgM, anti-beta 2 glycoprotein 1 antibodies, very long name, IgG and IgM. There are more antibodies. We have done research, and you, Sabino, for instance, are one of the top researchers in the world of other additional antibodies. Antiphosphatidylserine prothrombin, antiphosphatidylinosytol antibodies. Also, not only IgG and IgM, but also IgA antibodies. So there are other antibodies that we usually don't do in the routine laboratory. So that's the one possibility, is that patients present with these antibodies. And then you have to ask more sophisticated labs to perform these tests. Also, we know that there is another circumstance, that it's a very, very curious situation, is that patients present these antibodies, they present a clot, and these antibodies are in the clot. But what we look is the rest of the blood. We do a blood test of blood, not of the clot. And then probably most of the antibodies are in the clot, but not are in the blood. And then the tests are negative again. We know these cases because some patients that we have studied presented the antibodies before the clot. After the clot, the antibodies from the blood disappear, and sometime later, sometimes 6 months, even 1 year later, again the antibodies appear. So we call this transient seronegative antiphospholipid syndrome. So things are complicated. There are different scenarios in addition to the most classic scenarios. Fortunately, these are more rare scenarios, but for us, for physicians, these are quite complex. This means that we have to do more research in order to know better these situations.
Thank you for summarizing in a few minutes such a complex topic. And I think that we are getting closer to closing up. So I truly enjoy it. Thank you to both of you to sharing your knowledge, your personal experience about APS. And of course, there's to Reconnect to create this space for confrontation, sharing experience, knowledge, and see you to the next webinar. Thank you all.
Thank you very
much. It was a pleasure. Bye-bye.